the end of the story today. So instead of presenting findings from one study, I'm going to sort of present a series of a story that reflects a series of the research that I've done in the area of colorectal cancer screening. So I'm going to start with a little background on colorectal cancer and colorectal cancer screening recommendations, just to make sure we're all on the same page. For those of you who do work in this area, you can sleep through those first couple of slides. Then I'm going to talk to you about some work that we've done where we've described colorectal cancer screening use among insured populations. And then talk about some findings from studies of colorectal cancer screening in practice, as well as evaluations that are new approaches. And so in the middle here, I'll talk a lot about a large R1 that I had where we actually audio recorded office visits to see how patients and physicians talk about colorectal cancer screening. And some of the, because I haven't in all these years come up with a better term, cool things that we did with those data. And then I'll tell you about an R01 that I have now where we're building on it. So that's sort of the story. Is I'll show you the progression of my own research in this area. So just to start with a little bit of background on colorectal cancer. It is one of two cancers that's preventable. So we do not think that, or the majority of colorectal cancer does not arise de novo. It arises from adenomous polyps. And if you remove those polyps, you don't get cancer. And the good news is that the transformation of those polyps to cancer takes a long time. It takes 10 to 15 years. So we actually have some time to intervene. And if you catch cancer early, colorectal cancer early, the 5-year survival rate is quite high, over 90%. But only about 40% of colorectal cancer is discovered at the localized stage. So we are having cancers that could have been prevented or could have been successfully treated. And if it gets detected at a later stage, 70%, 70% is detected at a regional stage and 12% at a distant stage, and survival drops dramatically. And this is a picture of a polyp in a colon. So in 2008, the U.S. Preventive Services Task Force, or folks familiar with the task force in the American Cancer Society, they issue recommendations about routine cancer screening tests, among other things. And in 2008, both these societies issued, in those days, what were new guidelines for colorectal cancer screening. Both of the guidelines acknowledge that there are different modalities that are acceptable and equally effective for screening for colorectal cancer. Despite the list of things that are listed, the world today basically screens with a screening colonoscopy or with stool cards, usually fecal immune testing cards. And both of these societies, although they differ around specifics around which modality they're recommending at the highest level, both of these societies acknowledge that patient preferences play a role in which modality should be used, along with availability of resources, and say that the U.S. Preventive Services Task Force in particular says that you should be using a shared decision-making process when recommending colorectal cancer screening to patients. So this shows screening rates with the most up-to-date information that's available off of the Behavioral Risk Factor Survey. And it shows that across the country, about a third of individuals who are age eligible and average risk still are not being screened for colorectal cancer. Highly variable, state by state, highly variable within a state. And not surprisingly, when you look at colorectal cancer screening use in a primary care setting, when individuals are insured, screening rates are higher. So this is some work that I did fairly early on that I'm going to talk to you next about. And we were fortunate in that we did it once and looked at screening use between 1999 and 2003. And then we had the ability to update this for a later cohort of patients. So again, these are all insured patients and who are receiving care in a primary care setting. So they all had a visit to primary care. So some of those access barriers that we know exist in colorectal cancer screening have been already overcome as we get started here. In 2003, what we found, this is in an integrated delivery system in Southeast Michigan. You guys can guess which one, given where I used to be. I was at the Henry Ford Health System for 17 years, for those of you who don't know. But back in 2003, when we looked, 55% of patients who were eligible and due for screening at the time of their visit, who were age eligible for screening were up to date. In 2008, that rate had gone up to 69%. I can tell you it's only gone up since then. The thing to really look at here is the switch in modality for what's being used, right? Back here in the earlier time period, it was really a mix of colonoscopy and sigmoidoscopy, a combination, because if you have a positive stool test, you're supposed to go on and get a colonoscopy. And so that's some of what's happening in that combination. And I'll talk to you a little bit more about some of the other things I think now are happening in that combination. But when I published this, all I knew is that they were getting both tests, and the logical explanation was that it was follow-up colonoscopy. But by 2008, overwhelmingly, we've moved to a colonoscopy world in this particular health system. When we did the updated study in 2008, we were also working with a large integrated delivery system in New Mexico. The screening rate much lower, but look at the modality distribution, identical. Right? So the world has moved, and it's very clear the world has moved towards colonoscopy in many primary care settings where people are insured. Not true when people are not insured or underinsured. The factors that have repeatedly been shown to be associated with colorectal cancer screening are having insurance, having a regular source of care, and getting a physician recommendation. So access to primary care has a strong relationship. And I've shown, and Josh Benton and others have shown, that the more visits you have to primary care, the more likely you are to be screened for colorectal cancer. And that's particularly true if you have what's called a periodic health exam. Some of us call those checkups, right? So just a routine annual visit. So these are all people who had, they were all supposed to have had at least one visit, I think. Some of those maybe for like allergy shots, which is where we get to the 0. But these are people who were not up to, I always do this the wrong way. These are people who were not up to date with screening. And so what we see is that over 49% of these people had had at least one periodic health exam in the 5-year period where we looked to see if they were up to date. And then it wasn't just that they had one, but 12% of them had had 3 checkups. And on the other side, I'm just showing you how often they were being seen in general for other types of things. So this is not a group that hadn't had a visit. They'd all had a visit, and they remained unscreened for colorectal cancer. So with that as background, I actually got some internal funding from the Henry Ford Health System to survey primary care physicians to look at and have them tell me about if they'd received a recommendation for colorectal cancer screening. And so what we found with this survey that we sent to almost 2,000 primary care patients who looked remarkably like the ones that we were looking at screening rates on, that 80% of those folks told us that they had had a conversation with their physician, that their physician had recommended colorectal cancer screening. But when we joined that survey data with the automated claims encounter data, just over half of them had been screened. So that was the first clue to me that we potentially had a bit of a leaky bucket here, right? And so on that same survey, we asked about how they, not just did they get a recommendation for screening, but we asked a little bit about the content of that screening recommendation or that screening conversation. And we structured our questions around something called the 5 A's, which if you do work in primary care, it's a very common counseling approach that's recommended in primary care. It's an action plan-oriented approach, and actually the U.S. Preventive Services Task Force, if you read their white paper on how to communicate about how to do preventive health service counseling, they advocate for a shared decision-making process and the use of the 5 A's. So this was this was done with internal funds, and I had no idea if I asked people about all these different types of conversation components, would they just tell me yes for all of them? I had no idea. Sorry, were you asking a question? So, the good news from my perspective at this point was Wow, look at the variation in what people are telling us here in the first column. So it ranges from a high of 94% of folks were telling us, I think this is here, 94% of folks were telling us that the doctor actually recommended screening, down to a low of 33% for being asked about the preferences for different types of screening tests. And we also asked them if they were involved in the screening decision as much as they wanted to be, and we asked if they left information on the table. I think the question was phrased something like, did you have a question you wanted to ask the physician but you weren't able to? And in bivariable analyses, virtually all of these, except for this agree step, but virtually all of these were statistically significant in a bivariable analysis. And so we then put this into a logistic regression equation, and what we found is that 4 things come out as statistically significant. Uh-oh, there, sorry. So here, if I was offered a choice among available screening tests, and significantly, and I would argue substantively, if you look at this, the magnitude of the odds ratio here, less likely to have been screened for colorectal cancer If I received help making an appointment for screening, which is part of the assist step, I was significantly and substantively more likely to be up to date with screening. If I discussed with the physician how to get test results or arrange a follow-up, I was significantly, and again, I would argue substantively more likely to be screened. And interestingly, if there was a question that I had that I wasn't able to ask the physician about, I was, again, significantly and substantively less likely to be screened. And this model controls for all sorts of sociodemographic and other characteristics of patients.
Jennifer?
Yeah.
On the choice of screening test and the patient preference, could you maybe say something about how the relative the options and how they relate to each other, both in terms of pros, cons, risks? And I guess I assume some of this has evolved over time. So in your first 4 or so years versus your second, I guess I'm guessing maybe technology has developed and some things may have been
not
more.
with the recommended, well, so in stool cards, yes. So for colorectal cancer screening, there are, you can be screened with a colonoscopy, which some people would say is the gold standard, which is a tube is inserted into the rectum and you can view almost the entire colon. And you have to have sedation and you take heavy laxatives to clean your, strong laxatives to clean your bowels out. And not a pleasant process in general. You can have a sigmoidoscopy where you less sedation, more twilight used, and only about half of the colon is viewed. If you do a colonoscopy, it gets done every 10 years per the evidence supportive of it. If you do a sigmoidoscopy, it gets done every 5 years, and it misses some of the colon. If you can do stool test cards, there are different ways to do that with a GLIAC, or where you at home and in the privacy of your own home, from 3 consecutive bowel movements, you take a little bit of stool and swipe it on a card and put the cards in the mail. That's a less accurate test to do. Here come all the facial expressions for why the keynote for a lunchtime talk is not the place to be for this. And then the newer tests, you can actually just take one sample, or some of them I think you can actually swirl in the toilet. And those stool tests are looking for hidden blood. If you're doing the colonoscopy or the sigmoidoscopy, you're actually looking for polyps and abnormal growth.
So I remember a talk we attended maybe 5 or 6 years ago. There was someone, maybe it was even you, because a while back they were talking about there was a new stool blood test on the horizon that actually discriminate between kind of normal blood, like from hemorrhoids or whatever, versus blood that would be indicative of cancer. And it would get you up into the accuracy range, not as high as colonoscopy, but kind of within shouting distance. Is there anything new on that?
Blood that's from, I don't know about different, I'm looking to clinicians here for a little backup, because I don't know about different, where blood is coming from. It's all looking for hidden blood. There are now stool DNA tests that can be looking for genetic markers that are indicative of cancer. The stool DNA test, American Cancer Society may, I would have to go back to that slide, may be advocating, it's not commonly.
It's not ready for prime time.
Yeah, I don't think so. That doesn't mean the American Cancer Society might not be advocating for it, but yeah, I don't think it's there yet. There's a lot of ways to, there's also barium enema, which, in contrast on the word, gases are inserted into your, you basically inflate the colon, but none of these are really pleasant. So in one of the audio recordings I did, it's a primary care, it's a pediatrician who's in for his annual visit, and the physician says to him, have you been screened yet for colorectal cancer, or you haven't been? I can see in your EMR you haven't been. And the pediatrician says, yeah, I'm waiting for you guys to get a better test. So, this is the thing. This is not a little simple blood test that you just go and do. It takes a little bit of effort, and there are lots of logistical and emotional barriers around colorectal cancer screening. So it is a screening test that we have struggled to get people to engage in. But remember what I told you, it is a preventable cancer. And so there are different attributes to these tests, to get back to Dennis's question. And I'll show you at the end of the talk a little preference elucidation tool that we did with Sarah Holly at the University of Michigan to try to help people understand what their own personal preferences might be, given their preferences for different attributes, like the accuracy of the test. So if you do stool cards, you got to do them every year, and you got to fiddle with your stools. But you can do it in the privacy of your own home, and you don't have to do a lot of prep. If you do, and it's really now the choices between stool cards and colonoscopy. It's very few places are doing sigmoidoscopies these days. If you do the colonoscopy, you only have to do it every 10 years. The accuracy is much higher, but you've got to do this, you've got to take this very strong laxative, and people will tell you the prep is worse than the procedure, and you will be sedated, which for some people is a pro, that, they say, oh no, I want to be sedated, but it does mean you have to have somebody drive you, and you have to usually take the rest of the day off from work, and, depending upon what your work schedule is and what the art of the prep is where you're going to get it, that prep could be starting sort of late afternoon the night before, and you change your diet, you just do clear, but for the most part, clear liquids are the day before.
I mean, that's why I asked. It seems like if there is something based on DNA or something like that, it's some kind of stool-based test, but that seems like it would be potentially a game changer.
I think there's plenty of people out there working on it. The other one that I didn't mention is what's called a virtual colonoscopy, and you do hear people ask for that, where you swallow a little pill that has a camera on it, but you still got to do the prep. You still got to clear your bowels, and as I said, a lot of people will tell you the prep is worse than the procedure. So there's no perfect test. And the guidelines and the U.S. Preventive Services Task Force guidelines say colonoscopy stool cards are equally effective, right? And preference should play a role in what you get here. Okay, so let's keep going. So with that survey study as background, we competed for an R1 to actually audio record what was going on in the office visit. Because at the end of this study, I don't know who's being offered a choice, right? It's all patient reported, and I don't know if how to get test results are discussed before or after your test, where in the process these things are happening. So we argued that if this is preliminary data, that it was time to take a look and see. And I remember we had to resubmit the grant once, and one of the comments from one of the reviewers was, why do you think that it's all about patient-physician conversation? And I remember my response back was, I don't think it's all about physician-patient conversation, but I think it's an important part, and that we might be able to, I have evidence that we might be able to move the needle on screening rates by altering the way things are discussed. So we got this large study funded from NCI. This was back in 2004. And the overarching aims were to understand how shared decision-making in the 5 A's are being used in primary care to discuss colorectal cancer screening, and then to evaluate the impact of that discussion content and process on adherence to colorectal cancer screening use. So it's an observational study. It was done at the Henry Health System. We had 77 salaried primary care physicians who agreed to participate. That was just over a 50% participation rate among the medical group's physicians. And then once we had the physician on board, if you as a patient scheduled an appointment with that physician, we approached you, and we actually approached until we had 500 patients who agreed to have us be able to audio record their visit. So we had these audio recordings. We started off sending the RAs into the office visit with the patient. That seemed to be a barrier, and so by the end of the study, because we weren't accruing at the volume that we had wanted to be, we had stopped sending, and in one of the clinics, the offices are tiny and didn't have curtains, right? So what happened is during the physical exam, the RA stood behind the curtain for privacy reasons, and we went into one of our clinics, there's no curtains, and there are these tiny little offices, and so we said, fine, we're not going to send people in anymore. And so what the RA did was they went in, they put the recorder on the desk and turned it on, and walked out. And what we told the physician and patients was, if at any time, for any reason, you want the recording to stop, when the RA was there, you just tell them, they'll stop without asking questions. And when we left the recorder and we said, you just push this button, stop it at any time. The RA went in and out of the visit with the physician when they were in there. We never had an RA in there with just the patient because we were trying to minimize engagement between the RA and patients. Hard thing to do without the RAs feeling like they're being rude to patients when they ask questions. And never once was that recorder turned off. And we hear all sorts of things when you've got your spouse in there with you. We hear coaching about, Mom, you got to hit it when he's here. You got to hit it. You got to ask the questions. And, the banter back and forth. But never once was it turned off.
When did the consent, or how did the consent process happen?
How we did it was, so let me answer that. So what we did was we had a pre and post visit patient survey. So we would call you, we would watch the appointment scheduling system, and when we saw you had a visit, annual checkup visit with one of the physicians who'd agreed to participate, we would call you, and over the phone we would get you to verbally agree to participate, and hopefully get you to fill out a short survey at that time. If not, we would arrange follow-up for that time, and then we asked you to present to your visit about 15 minutes early. And at that time, we got written consent before we ever audio recorded. So we collected some data without written consent that we were, had IRB approval to do. But we met you in the office. And then we had a post-visit survey. And that's where things get tricky, because the one thing that I had to promise to all these primary care physicians was I was not going to mess with their patient flow. Because that is a big deal. These are RVU-based guys, and they are moving people in and out. And if I'm sitting in a room asking people questions, I'm hogging a room that doesn't have the next patient in it. So it was sometimes very tricky to get these post-visit surveys, but we got most of them. We were asking about their preferences, their relationship they had with their physician, and their perceived risk. Post, we're asking them just some general information about their impression about what decision process was used, and then some relational communication variables. And then we link that with claims data for the subsequent 12 months to get their actual utilization data. And we also have this claims data for the pre-period too. So I know I was just talking to Joel about another publication we did off of these data where we know what they were, all the preventive services they were eligible and due for before. So what we found, this is from observer coding, so all of our audio recordings were transcribed verbatim, and then coders listened and read along while they were coding. And we did, the investigator team first, we immersed ourselves in the data and listened, and then came up with a structured coding worksheet that included some items from things other people had used previously, as well as things that we developed ourselves. So what we heard is that 93% of the visits included a physician recommendation for colorectal cancer screening. So among these patients who were eligible, this is in an environment that there is a HME prompt, a EHR prompt for colorectal cancer screening. 88% of those conversations are initiated by the physician. And what we found that I don't think was previously known is that over a third of these conversations, and over a third of them, you could hear from what was said that this patient and this physician had talked about colorectal cancer screening last year, but the patient remained unscreened. And who knows how many more it occurred. And this is just where either the patient or the physician brought it up. And when the physician would bring it up, we never once heard a patient say, no, you didn't tell me to do that. What you heard is, yeah, I know that form is still on my desk, or my wife said you were going to bust my chops over this. So this is not that patients didn't hear this last year.
Just a clarification question. 50 to 80, the males 50 to 80, is that right? Just
yeah, these are 50 to 80. Yeah.
But everyone, I mean, if you were 52 and you had a colorectal cancer, you would not be eligible. So
that's right. So these are everybody who we recorded this visit on was average risk and due for.
Okay.
To the extent, I mean, there's probably some high risk folks in here that we couldn't weed out, and then there's a few that we made ineligible because, like, one of these patients is a lung cancer survivor, and or some cancer that had a recurrence, and they're active, and the physician sort of says, let's not worry about all that.
But if you got one of the tests that was good for 5 years or 10 years,
we have the appropriate look backs. So we look back 10 years to make sure no colonoscopy, 5 years to make sure no sigmoidoscopy, and 1 year for stool card. And I think we already looked back for barium too. Yes.
So you said due for to know if it was first time or not?
So we do know that from the data. We didn't see a lot of first time for screening. Yeah, we do. It gets trickier. So when these were done 10 years ago, there weren't a lot of colonoscopies happening, right? I mean, we were just entering the colonoscopy era here. But we do know if it was their first. Some of these, it could be a repeat. So we coded for Kathy Charles's criteria for shared decision making. This is using her definition of the 4 components that need to be present, and we really didn't find it happening at all in these visits. So if you are using an academic definition of what shared decision making is, our coders could not find shared decision making there. And we tested inter-rater reliability. I'm not reporting all that today, but we did pretty well with that. Before the visit on the survey, 70% of patients told us they had a preference for a shared decision making process for screening tests. And after the visit, only 47% reported sharing that their process was shared with their physician. But that's more than the 0% that we actually coded. And patient reports of the shared decision-making process only matched their preference 49% of the time. So most patients report wanting to use the shared decision-making process, whether or not we're looking at this from an observer point of view or from the patient's perspective. Most decisions are not shared. And then in both bivariable and multivariable analysis, I can tell you that neither definition of shared is associated with colorectal cancer screening use. So we also looked at the information that was both of interest to the patient and provided during the visit. So this is showing, the first column shows the percent of patients who rated that information as very important. And the top 3 are really consistent with informed, the top 4, informed decision-making, right? So 89% of patients told us it was very important that they know about what the test is for. Lots of times what you hear in the audio is, it's time to get your colonoscopy. The computer says it's time to get your colonoscopy. but no statement around what that's for. Discussion of pros and cons, 86% tell us it's very important. Test accuracy, 85% tell us it's very important. And testing alternatives, 83% tell us it's very important. And then we also asked about the testing process, the logistics, and 78% told us that was very important. We had a couple decoy questions in here, like the how important is it for you to know the manufacturer of the test? And I'm sorry, I'm not going to remember off the top of my head now, but it's a much lower percent, like below 50%, who tell us it's very important. So we think people were paying attention to what they were answering here and not just checking very important for everything, at least some people. And then down the right-hand side, the far right, are the percent of people who received that information during the visit. And we've divided pros and cons up into just looking at pros versus just looking at cons, because you might say, well, it's so low because they didn't do the cons, but that's not the case. In general, the pros and cons are not discussed. We also looked at whether or not physicians were soliciting patient questions regarding colorectal cancer screening and found that to be a very rare occurrence, despite there being explicit prompts from these physicians. 49% of patients asked some sort of unprompted question about colorectal cancer screening. In fact, 270 related questions were asked across the 415 visits. The majority of those questions actually centered on logistics. And in this setting where the Henry Ford Hospital is in downtown Detroit, and a lot of the clinics are in downtown Detroit, but more clinics are out in the suburbs. One of the questions is, do I have to go downtown to get that test? And the answer is no, you don't. But we hear that a lot, and so that would count as a logistics type of question. So most patients report information on test accuracy.
What about payment or cost?
So these are all insured patients, so they're all covered. You do hear that come up, and we're actually in my inbox over the weekend came a paper. I gave some of these data to a junior colleague years ago who was going to focus on the barriers that patients reported, and that's the one paper that's not been published yet off of these data that we're actively working on. And cost it's there, but it's not the major barrier that gets raised. In fact, the major barrier is the handoff to GI.
So does that cost include things like co-pays and follow-up costs as well? Do you use that?
So in patient, they're just usually at this stage what patients are talking about is if there's a copay. Like, does my insurance cover it, or is it even a covered service? These were pre-ACA days. Even today, I don't think patients know that colonoscopy is covered by all insurance as a screening colonoscopy. It gets tricky though, because if it gets switched over to diagnostic, sometimes it's not covered, right? But in this health system at this time, if you got sent for a screening, these patients, if you got sent for a screening colonoscopy, there was no copay for that screening colonoscopy. You'd already faced your copay, which was to see the primary care physician.
Because I've actually heard of instances where people blood test, which is positive, and triggers a
and it's diagnostic, right?
Colonoscopy where it's not covered.
Right, and what I've had, a gastroenterologist tell me years ago is I can make everything diagnostic because I just pluck a little something for a biopsy and then I get paid more. That's coming from a salary gastroenterologist. Yeah, so I do, but this study did not deal with that, and I've not done studies looking at that. I did, actually, years ago, I published something on false positives, and we did look at downstream colonoscopy costs, but it's been a long time, and I couldn't tell you all of what we did with that study. It's been a long time. But we did try to consider the downstream costs in that one study.
We've had one insurance company here in Pennsylvania that's actually covered all those things.
Yeah, and my guess is that you could probably, these were all, so the Henry Ford Health System has an in-house insurance mechanism and an in-house salaried medical group. And my guess is because all these patients were getting their care with the in-house medical group, that you would probably be able to successfully advocate for coverage. But it might take advocating depending on some of the policies. Okay, so most patients report that they want information on accuracy on the disease that they're being screened for, on the pros and cons and the alternatives. Many, if not most, visits don't contain this information, yet half of patients ask questions specific to colorectal cancer screening, and the questions they're asking are not filling the gaps that they say is important. They're not being, I mean, I'm not putting this burden on patients alone, I'm just telling you the patient side, right, here. But I also told you physicians aren't asking either. So then we looked at the different test attributes and the preferences for them. And we had a whole long list of test attributes, and we used a rating and a ranking process. And what these are from the ratings, these are the 3 most important test attributes that patients told us they considered: the accuracy of the test, the risk of complications and side effects or pain and discomfort while taking the test. And then we took these attribute preferences, and there were like a dozen or so different ones that we had listed, and we came up with an algorithm to try to determine what we thought the patient's preference modality would be. We've since then used conjoint analysis and more formally come up with that, but we came up with this algorithm here and decided whether, based on what you told us, we thought you had a strong preference for colonoscopy, a weak preference for colonoscopy, a strong preference for stool cards, or a weak preference for stool cards, or that your responses weren't consistent with any modality preference. And what we found is that about 40% had a weak or stronger preference for colonoscopy. Almost a third had a preference for FOBT. And then we had, 23% of patients, probably that pediatrician who's asking us to come up with a better test, right? The attributes were not consistent with any test, and so it wasn't clear to us what it was they would pick if faced with the choice. So what happened during the visit is that, and this is where, remember I told you that we had this group back in the very first study I did that were getting both modalities. And here you'll see the majority of patients get a recommendation for a colonoscopy only. Very few get a recommendation for an FOBT. And almost 20%, 19%, get a recommendation for colonoscopy and FOBT. And this was actually a stumbling block to publication, because we had reviewers who kept saying to us, no, that doesn't make sense. Those tests are not both recommended. But we have audio recordings, so we can hear that both those tests are being recommended. And in one of them, we have a patient who says, well, wait a minute, if I do those stool cards, then I don't have to get that colonoscopy. And the physician says, no, you still need to do it. So I don't know if this is a hedge your bets sort of, I don't know if this is physicians really prefer stool cards, prefer colonoscopy, but tell you to do stool cards to get you to do something, or is this a lack of understanding on the physician's part? But this caused me to go back, and I was telling somebody this morning, it caused me to go back to NCI, did a very detailed survey on physician opinions around, or practices around colorectal cancer screening, and the way their questions are worded, they are basing it on the assumption that nobody's doing this and so the way the questions are worded, they totally missed this in their national survey of physician practices, self-reported practices. And it's not just limited to one physician. We looked. It's not just limited to one physician. This was sort of across multiple physicians. So that's what gets recommended. During the visit, 23% of patients, either prompted or because they themselves initiate a conversation around their modality preferences. Overwhelmingly, that's for FOBT, but of course it is, because overwhelmingly they're getting told about colonoscopy, and so if that's your modality preference, you probably don't have much reason to raise it, right? And among those with a prior recommendation, we did see the physicians more likely to be including FOBT in their recommendation. So I think there's some of the hedging your bets. I want you to do something. So when asked, patient modality preferences are not monolithic. We showed it with our data, but other folks like Sarah Holly, who we worked with on this, have shown it in more sort of formal conjoint analyses and explicitly asking patients what modality not through the attributes find the same thing. Patients are rarely asked or expressed a modality preference during the visit, and physician recommendations are overwhelmingly for colonoscopy. So then we looked at the use of the 5 A's. What you're supposed to do here is assess whether or not the patient is due, advise them that they are due and that colorectal cancer screening is recommended, and then you do a course of negotiation and agreement around how we're going to get screened for colorectal cancer. You offer assistance. In this case, that's around how to schedule the endoscopy or verbal indication that we gave you stool cards or that the nurse was going to give you stool cards, and then arrange follow-up. And arrange follow-up can be in 2 different ways. So if the patient is agreeing to be screened, then we can discuss how the test results would be relayed. So if your stool cards are negative, I'll send you a letter. If they're positive, I'll give you a call. Or if I send you over to get the endoscopy, the colonoscopy, then the GI physician will give you those results, usually on the spot. Or if I'm saying, no, this is not for me, then I can arrange follow-up by saying I'm going to revisit this discussion. We'll talk about it at our next visit. You think about it and we'll talk about it. So just like in our survey, we found variation with advise being the most frequently discussed component of the 5 A's. And assist being second most frequent. So we tell you to do it and we tell you how to do it. And then only a half had any discussion around why you're due for screening. And here we even included, because the computer says you're due for screening. There's a prompt here in front of me that's saying you're due for screening. So we were pretty liberal in our coding. In all our coding, we tried to be liberal. Which is great for the descriptive stuff, but maybe not so much for when we try to link it with actual screening use. 15% we thought contained some sort of negotiation of a screening plan, and only 3% discussed follow-up. But that could be, the 3% here could be if you're recommending a colonoscopy, they just don't go there, because the GI clinic will talk to them about how they're going to get their results. So then, overall, we looked at the number of steps of the 5 A's. If you read the task force guidelines, it should go in that linear order is what it makes it sound like. If you listen to any office visits, and if you've ever been to an office visit, and if you give this presentation in front of a room of physicians and you start talking about that, it's just like dismay. Because that is not how conversations go in an office visit. But we counted up how many different components of the 5 A's were involved. And this is just showing you that only 43% had 3 or more. When it was 3 or more, it was most often advise, assess, and assist. And before that, it's advise only or advise and assist. So when the patient is due, physicians often recommend screening or advise. Many of those are repeat recommendations, and there's relatively limited application of the 5 A's. But patients who get 3 or more of the 5 A's are more likely to use screening. And what we found actually is that at the end of the year, 53% of these patients who had received a recommendation actually went on to be screening. So big leaky bucket here.
Can I ask another question?
Yeah, sure.
So,
I don't know if I can answer, but we can try.
what's the marginal increase in detection probability of the population of moving from blood test to colonoscopy? I know it's better. I guess the question is how much better?
So not enough better that the U.S. Preventive Services Task Force recommends one over the other.
Really?
Yeah, the task force says these are equally effective, and in fact, in an RCT environment, only FOBT has been studied. The colonoscopy studies are not from randomized trials, but in the but the colonoscopy gets used as the gold standard in the FOBT, right? It's a hotly debated question, and the American Cancer Society says you should stick with the structural, the structural exams, the endoscopy exams.
But, what are the criteria there? Is it mortality? So
Yes.
that's a little bit different answer. You know, that if you do the stool cards, then it's probably going to be later detection.
That's
It's not
right.
going to be a matter of finding a polyp and during
There's no prevention.
having that snipped off and no work.
Right, there's no prevention with it.
So,
There's no primary prevention.
yeah, so the stool card, maybe there's no difference in mortality, but you probably are looking at a higher likelihood of having
Morbidity.
morbidity untreated.
And if your stool cards are positive, you're going to go get the colonoscopy to confirm the positive test results.
Real cost.
So any screening has been shown to be cost effective, and I'm trying to think what the answer is for the cost effectiveness. There has been a couple of simulation models around this, and I don't remember that one arm over the other was more cost effective, because what happens with stool cards, you've got to do them every year, and adherence goes down. So there's efficacy and there's effectiveness, right? And the effectiveness is lower than the efficacy with the stool cards, because people don't do it every year. And getting people to do it every year in the visits to get them in and to get it done. So what we saw in this audio, so it's kind of cool, right? The frequency of the components of the 5As from the audio recordings kind of matched the frequency that we saw in the survey, and the screening rate kind of matched, right? So patients, I think, are hearing the same sorts of things as we're observing when it comes to colorectal cancer screening. And now we know things like maybe the reason that patients who were offered a choice were less likely to be screened is because it's patients who were hesitant to be screened who were being offered a choice. Although I'll tell you, we looked, and if this is a repeat conversation, you're equally as likely to be screened. If we can hear that it's a repeat conversation, you're equally as likely to be screened in the following year as if this is, as far as we can tell, a first-time recommendation for screening. Equal, no difference. And one of the primary care physicians told me, he said, well, I just keep recommending colonoscopy, and eventually I wear them down. And these data would support that, that premise, that observation in the clinic. We sort of see that here. Eventually they wear you down. And I wish I knew what it was that pushed people over. So here's my summary from this set of analyses on this audio recorded study. You don't always get what you want. It's rarely a shared decision-making process that's used. The information that patients tell us is important is not provided, and physicians tend to recommend colonoscopy, colonoscopy, colonoscopy. You often get it again. Over a third of the time, this patient and this physician have previously discussed screening, and with the exception of the modality preference, the modality difference, not much difference in the rest of the conversation. Some seem to get what they need, just over half go on to be screened, and patients can be worn down, but many remain unscreened. So here, and I was talking to, I was not here, Xin Feng earlier this morning, about, if you look at these data with a decision scientist hat, right? A decision scientist says this is a choice, whether or not to screen in and of itself is a choice, and there's a preference around modalities. So if I'm wearing my decision scientist hat and I say, is there room for improvement in the decision-making process? I get to raise my hand and say, you betcha. There's a lot of room for improvement in the decision-making process. And then if I take my decision scientist hat off and put it on the table, and I put my public health hat on, which is a pretty big hat in my world, in my training, if my goal is to get people screened with an evidence-based screening modality, I get to raise my hand and say, you betcha, because only half of these patients are going on to be screened. So what might improve screening rates? Putting maybe my public health hat on here a little bit more than my decision scientist hat. I was involved in 3 different interventional studies that were happening sort of as this audio recording study was in full gear. One was looking at patient reminders in a Kaiser. Actually, I think it was group health, but pretty soon that's going to be the same. Tailored messaging. So the first one was done with Adrienne Feldstein, who's a primary care physician at, she's Kaiser Northwest. Sorry, I'm too confused. And then the second study was looking at using tailored messaging. Ken Resnickow was the PI for this, specifically targeting African Americans. And the last one was working with Sarah Holly, who does preference, builds decision aids for preference-sensitive decisions, and she had built a decision tool, Decider Guider. So I'll tell you a little bit about what we learned from these studies. For the automated telephone reminder, we targeted average risk, age-eligible health plan members who were due for colorectal cancer screening. We randomly selected 6,000 of those, and then patients were randomly assigned to usual care or to get an automated call. This was back in 2009. If you got the call, there was a general reminder call that lasted about a minute that very quickly talked about the benefits of screening and encouraged FOBT as a simple way to be screened. And the recipients could request cards. So one of the things that drives up the FOBT campaigns that you hear about when people mail cards out is that we mail cards out to everybody. They're low cost, but when you mail them to a large number of people, cost goes up. And only a very few percentage of those send them back. So this was trying to get folks who were motivated to complete the cards to tell us so we could send cards out. And we did do some cost effectiveness analysis here, and it's much better to have this process than cards being mailed out without it. And then there was for those patients who requested cards, we sent a follow-up, or there was a follow-up phone call. So we saw an increase in screening rates in the intervention versus the usual care group. It worked equally well. Somebody asked me about previously screened folks before. This intervention, we tested that it worked equally well for those who hadn't been screened, but less than a quarter of the target population was screened. So we left a lot of folks out there unscreened. In the tailored print messaging, this was, again, average risk, age-eligible individuals. These were all African Americans who were due for colorectal cancer screening, and all insured patients. These folks were at the Henry Ford Health System. Patients are randomly assigned to receive 2 minimally or 2 enhanced tailored print newsletters. And the newsletters are equal content in terms of length and graphic display. The minimally tailored were based we know tailoring works, so the minimally tailored were based purely on what we could get from the electronic health record. So it was really gender and race is what we can get from the health record. And then the more enhanced tailoring, we asked a long questionnaire beforehand. And I think this tells, so here it is. Minimally tailored was based on age, sex, race, and screening history. Enhanced had all of those, plus we asked about their personal barriers to screening, their intention to screen, their preference for decision style. Do they want to make decisions on their own, or do they want the physician to make those decisions for them? There are questions around medical mistrust, ethnic identity, informational preferences, and procrastination. And the message content, the first newsletter focused on barriers, finding personal motivation, and the screening experience, whereas the second mailed newsletter focused on overcoming procrastination, health benefits of screening, and barriers. This is an example of a page. This was done in Southeast Michigan, so we picked up on the auto theme. And I can't remember in total how many pages, but it comes like a little booklet for them. And it looks exactly the same. It's just that sometimes the text is tailored based on a lot of things, and sometimes it's only minimally tailored. One of the things we did was as I said, we asked them their decision-making preference. I would rather be told what to do. I want my doctor to tell me what to do. And based upon their responses to that, we worked out whether they had a preference for autonomous decision-making. So this is consistent with self-determination theory. So if their preference is for autonomous communication or decision-making, we have the messages written in what we call a pull tone, and versus more directive, which is a push tone. About half prefer the autonomous. And this slide, with any luck, is showing you the subtle differences in how that tailoring works. So if you want directive language, we tell you that this newsletter will help you get your colonoscopy done. And if you want more autonomous decision-making, we say that this letter will help you decide to get your colonoscopy done. Versus the second one is saying help you ask your doctor which colon test is right for you, if you want your doctor to make the decision, versus on the right, help you decide which colon test is right for you. So that's the difference in language that gets used. No difference at all in screening rates between the two groups, but we did find that results were moderated by their autonomous decision-making preference. So if you had a preference for autonomous decision-making and you got the deeply tailored intervention, which used language consistent with your desire to make your own decisions, then you were more likely to be screened.
So these three different approaches, the text messages, I forget what you called them, but you started this whole thing off with the three different patient reminders, tailored messaging.
Right, so two different studies, right? So in the one study, we're testing reminders.
I got that. I guess the question I wanted to ask is, did you think of any kind of financial incentive, either in the form of a reward or penalty? And with the ACA, under kind of the guise of wellness, employers have had kind of a lot of, most employers have taken that as a little bit more of a stick rather than a carrot. But you could imagine, there's lots of incentives to do an HRA and to, do a biometric screening. But you could imagine co-insurance for your premiums or rewards. I mean, lots of things being tied to actually getting this done.
Pay you to do your colonoscopy.
Yeah, under the VBID kind of type design.
So I've never done that. Kevin Walt approached me a number of years ago about that, and wrote a grant with him that wasn't funded, and a program project, and I actually convinced him to let me focus on diabetes control and not colorectal cancer screening, because I thought it was more interesting to look at a more complex behavior than a one-shot deal. But yeah, I mean, I've not done any. I have a colleague who's doing some behavioral economic stuff for weight loss.
Right. Any sense of, like, if you were an employer, say here at the university, where we have 18,000 employees and 45,000 covered lives, so, let's say there's maybe 15,000 in this age range, I'm just guessing. If you were to offer some incentive, maybe $100 if you get this, I mean, could you make it, if you did the math in terms of the down the road savings, assuming these people stayed with the Penn State insurance for a while, I mean, could the future cost of or future mortality justify
I bet you could make a mathematical argument for an ROI on it, just because avoiding a diagnosis of late-stage colorectal cancer is an expensive event, right? And the later the stage, the more expensive the event is, I would guess. But if you gotta believe that. The question, I guess, is if you use that sort of external motivation, you're probably going to have to do that same external motivation when they're due again. And what we don't know is whether all these people who've had these colonoscopies are going to go back and do it again. We do not know that. That 10-year clock is just starting to tick, and that's, I think, why those rates nationally in screening rates in places like Henry Ford are up so high. But as all those people who did it once, they got to go back to keep those rates high. Yeah.
I have a question in regards to your second study that included 881 African Americans. Was that race and ethnicity variable direct data, or was it assigned by the physician?
So it's not assigned by the physician. It's usually the front desk staff who assigns race. That's not the case anymore at Henry Ford, but in those days, that's how race got assigned. But on the pre-visit survey, it was confirmed. Right.
So the patient
So
also identified themselves as African American.
Right, and then some of the ethnic identity questions, like a reason to be screened. Some of the things that I didn't present because it's not really my area of expertise, but it's something that Ken Resnickow is very interested in, and it didn't seem to matter here. That is, I want to do this for the betterment of my race. I want to set an example for, he asks those sorts of questions, and then depending upon how you answer those questions, you might get quotes from Oprah Winfrey versus, depending on how much you're identifying with your race. And but I don't talk about it because I don't feel qualified to answer a lot of questions about that. But everybody in that study eventually self-identified before they were enrolled in the trial. So about decision aids, and this is something that really intrigues me. If you put on that decision scientist hat, decision aids are supposed to be unbiased aids that were originally developed to be used collaboratively with, when I'm standing here, I feel like I'm probably flicking my hand at people who are in the audience further out. Used side by side between patients and physicians. But we know that that's not how they get used. And so Jimbo and others at Michigan have recently done a literature review on decision aids. The finding on those, this is in cancer that they did this review, is quite mixed in terms of their impact, and it's very clear that they don't get integrated into clinic processes very well. And they note that a commonly missing component is a explicit values clarification exercise. And Sarah Hawley was part of the team that was on that, one of the authors on that review, and she had built this decider guider, or was building, when she and I started collaborating, building this decider guider tool, which is specifically designed to help patients work out what modality of colorectal cancer screening is most consistent with their preferences. Because the idea or the hypothesis is that if you could actually get patients to get a recommendation for a modality that is consistent with their preferences, they may be more likely to be screened. So this was a 2-arm randomized control trial. It was conducted in the VA, and then it was also conducted in the Henry Ford Health System. You either got the decider guider tool, which I'll show you some pictures from, or you got standard information. The decider guider tool got this preference clarification exercise, and at the end of both of these online tools, each group was asked to select the test that they most preferred. These are the attributes of the test that were shown to vary in the tool when we were doing the preference elicitation. The nature of the test. So this was done in the days when sigmoidoscopy was still being done. We're reusing this for something now, and we're actually getting rid of all the sigmoidoscopy-based attributes. So the long tube with sedation is for the colonoscopy, collect stool sample at home, is for the stool cards. The short tube without sedation is the sigmoidoscopy. The accuracy of the test is either very good, 95% with the colonoscopy, or less good, about 40 to 60% of the time. The frequency of the test, we've talked about these, and the follow-up required, and then the preparation required. So all of these we've talked about earlier today. And this is what the tool looked like. 2 attributes would vary, and then along the bottom, it's it says, I strongly prefer option 1 all the way to I strongly prefer option 2, and people mark the bubble along the continuum for which option they prefer, and then you go through a series of these, and depending upon what your responses are, then, depending upon what your responses are, then at the end of the tool, you get a little page that says, based on what you told us, your top test seems to be an FOBT test. And would you like more information on that? And then there was actually a piece of paper that could be printed out, and these were all done on the way into an office visit. So a piece of paper was printed out that you could take in to the office to talk to your physician about what test. So these results haven't been published, probably because there's no significant difference in screening use at 6 months between the two arms. There is improved knowledge with the tool, and decider-guided users were more likely to use a preference concordant tool. So what works? Decision aids, they alter the mediators for sure, we know that, but often not the behaviors. Patient reminders and removal of structural barriers certainly has been shown to be effective. One-on-one interactions, I didn't talk about that. I've not done any navigator-based studies, but navigator studies certainly work. The challenge is that you really can't afford to do these in average risk-insured populations. Health systems just don't have the resources to do those sort of high-touch programs. And it's not that scalable. So where do we go from here? I think we've got to focus beyond the receipt of a recommendation, and we have to, remember what I was taught at Michigan years ago, that access is both an entry and a passage through the healthcare system challenge. So there's barriers to patients receiving screening at the time of the physician recommendation, which is this passage piece, right? And I think we've got to integrate with existing clinical processes. I don't think that you can do this as a standalone sort of thing. I'm always thinking about scalability from the beginning. I think that's in part because of the number of years I spent at Henry Ford and the number of times I would go in and I have a great idea for what we could do, and they would look at me like I'm crazy, because where were they going to get the resources to do that? And so I began thinking that patient portals perhaps provided some unique opportunity. And I have to tell you, from early on in listening to the audios, I felt like everything we've been doing, we've been intervening at the wrong time. That it wasn't before the visit that we needed to intervene, and it certainly wasn't on the shoulder of patients that we needed to intervene. So with the prompt in the EMR, the recommendation was happening, and all this stuff we were doing before visits for patients wasn't having an effect. But if you listen to those audios, you can hear that cue to action. You can hear the physician gear the patient up. And I thought early on it was post-visit that we probably should be doing something, and saw the patient portal as an opportunity for that. I think it can't be a single approach. It's got to be multifaceted. We've got to combine reminders with information, and we've got to include some sort of values clarification exercise to undo that colonoscopy only that's being recommended during the visit. And from the tailored messaging stuff, I think that, and the 5A's stuff I've done, I think we need to be incorporating the 5A's, and then the 5R's are if people are not agreeing to screening, you divert from the 5A's and do more motivational interviewing, which is totally consistent with the autonomous decision-making pull language. So we submitted an application. I submitted an application to NCI. Just got funded in August, so I don't know what that means. I submitted it in probably February cycle, right? Or maybe the fall. So eAssist is our idea. We called the tool eAssist. We had lots of conversations. We thought about calling it e-navigation, but we thought we would probably run into barriers with folks on a study section who are navigation advocates, because a big deal with navigation is that personal touch, and this does not have that human interaction. So this is an online, scalable, post-visit decision support tool. It's not a decision aid. Our goal is to nudge you towards screening, and along the way, make sure that you are informed about what your options are, what the pros and cons are, and give you an opportunity to extend that office visit conversation beyond the walls of the exam room, so that it's not a year before you have that conversation again with the clinician. So it combines important decision-making context with removal of personal and structural barriers, and it does so by leveraging that cue to action that's provided by the physician and the portal population. So hopefully this now seems like a logical argument to you guys from the story that I've told. Our premise, our working premise, was that a driving factor behind the underutilization of colorectal cancer screening among insured folks who were visiting the physician is the gap that exists between the physician recommendation and the patient's receipt of screening. And our tool is designed to try to support patients in that screening decision, in the receipt of screening, once they have a physician recommendation for care. So we have, at the beginning, we're assessing the patient's decision stage regarding screening. So if you're ready to be screened, sign me up. You get branched one way. If you're not ready to be screened, you branch another way. We assess their communication preferences and other specific patient factors. We're providing personalized information about screening alternatives, the benefits and risks, and we're addressing screening barriers. So we're actually recycling bits and pieces of other interventions that I've been involved with over the years. Decider Guider is in there for modality preference clarification, so we're whittling that tool down to just the little conjoint analysis, but we don't make everybody do that. We show you a little side-by-side to compare colonoscopy with FIT test, which is what's being offered in the health system today. And if you can't make a decision at the end of that, we say, well, use this tool, and we'll help you make that decision. Screening barriers, we know from some work that Risa Jones has done, and she has an R01 now where she's developing barriers, videos to address patient barriers to screening. Her work shows that patients have general barriers to colorectal cancer screening, but they also have modality-specific barriers. So we are picking and choosing the most prevalent barriers and offering those videos within the tool. And we have assistance with completing screening in that if you, through the portal, we're linking to the messaging system in the portal. So if you want, we thought when we got started that the research team would mail out stool cards to folks. That was our plan. And we were working with the health system to get permission to do that. And because we have a clinician team of primary care physicians and the GI clinic, and there's a reason why you need both, because the process, the leaky bucket, remember, actually has a lot of leaks in the GI clinic with open access. But our plan was, we'll step up to the plate, we'll do this, and we'll worry about tossing the mailing function out afterwards. The health system said, no, we already have a process in our clinics. If somebody requests stool cards, we know how to do that. So those messages are going to go directly to the clinic. And the clinic is going to mail the stool cards, and that's, to me, that's very exciting that the health system is on board and that they want to integrate this with their current clinical process. And then we have follow-up messages and reminders. So we know if you've scheduled something, and we know if we've mailed you cards or if you have cards. So we're still negotiating we're running patient focus groups to help us decide what frequency and when those reminders should come, and the same with clinician work groups. We're plugged into some primary care quality improvement teams as well as a GI quality improvement team to get their input. So that this is all done based on information that comes from patients and clinicians. And this is just showing you, it's based on the modules, if you will, within the tool are based on the 5 A's. If you say you're ready to be screened, then we go right to assist and arranging follow-up. But if you say you're not, then this is where, roadblocks are the barrier videos that you can see, and relevance and risk, the pros and the cons of screening. So we're in the process right now of building this. And it gets, this is a more detailed flow diagram of what we're building, but this is where we are with all of our landing screens and all of our conversations with the clinicians and the patients. We just got IRB approval for our focus groups, our patient focus groups, so those are starting. So we have some screenshots to show them and some general flow questions to talk to them about. But that's what we're doing. So I'm pretty sure that's the end of oh no, I see, I have more I can tell you. It's a 2-1, well, and it may be actually, when we wrote the application, we thought we were going to trigger this off of a primary care visit. And we were awarded it, and we were going to do a 2-arm study. We were going to have people be routed to eAssist through the portal or be routed to something like the CDC Screen for Life. And in working with the health system, what we've learned is we can actually trigger the beginning of eAssist off of an order for a colonoscopy or an order for a fit test. We were going to have to make the assumption that 93% of people who had this type of visit got a recommendation. We don't have to make that assumption anymore. So we can trigger the start of this process off of the order. And what we've learned is that embedded in the patient portal, multi-clicks buried down, is some general health information. It's an Epic system, so I think it's called HealthWise, the patient education material. And we just think nobody's going to it. So we're in the process of collecting some preliminary data now around the number of eligible patients that we anticipate having off of this order mechanism. So that what I'd like to do is do a 3-arm study. I'd like to have usual care, which is they just go about their business, a middle ground where we actually point you to the patient education material that's already available in Epic, and the 3rd arm, which is this more sophisticated tool that we're building. Because if all you need to do is point people to the information that's already available in Epic, life would be a lot easier for the health system. But I'm a little bit worried about making that our sole comparison group and having nothing to talk about in a paper.
So we should probably see if there are any questions before we wrap up. Any other thoughts, questions?
If you could, talk a little bit about sort of rescreens. You mentioned that a little bit, but do you think, for example, this is going to be more important for people who have been screened once and are now coming back at a later point in time, like, a year after their first FOBT test?
My guess is it'll be better, it'll be more effective for new screeners than rescreens. Maybe for people who've got to come back and do a colonoscopy, but I don't know, we've not seen huge differences, but historically, we've not had large enough proportions of rescreeners for colonoscopy. Like, what are those folks going to choose? Again, I don't know if anybody has looked at that in this group, but it's,
I was actually thinking about the fecal test.
Yeah, well, I think for people who pick that, so we're just doing, we are not, this study is not designed to deal with that. My gut instinct working with the health system is they'll leave this tool on and it will help. We know that adherence annually to FOB tests is problematic. And this is a health system that will periodically mail out FOB tests or fit tests now, because it's an easy way to get their screening rates up for HEDIS and other things. If people don't come in, or it's just easy to not do things, right? And once we know you have cards, we're going to keep sending you messages until you turn those in, up to the point that the patient groups say, we think you need to stop at this point, right? And the night before the colonoscopy, we're gonna, or 48 hours is our thinking, but we don't have input yet from the clinicians or the patients. We're gonna send you stuff about, RABA, you can do the prep, don't forget, and
One more.
Just a question in regards to the logistics. It seems like your interventions are provider-based within the clinic, but they are insured. And I think you have insight as to the percent of the co-pays or whatever's involved with the patient. My question to you is, have you ever interacted with the insurance body themselves and have them supplement a letter or something that reiterates the same messaging that you are disseminating through the provider end?
so I've not done that. A colleague of mine, so at the Hungerford Health System, we tend to send them, when I've worked with them, we've tended to send the messages from the provider group because we feel it's a stronger message from their doctor than their health insurance company. Risa Jones, who's a colleague of mine at VCU, has a large project with Aetna in Minnesota, I think it's the whole, and she's working with the insurance company, and they are doing, community-based campaigns, and I think being successful working with a health plan to promote colorectal cancer screening. I don't think I've ever done any work with the health plan. We often, within the Henry Ford Health System, we often target the patients who have PAP as their health insurance mechanism, but we do that because we know we can see all of their use and we know that they have coverage. But I've never personally done something. Like at a Kaiser, it's one and the same, right? So the stuff I've done at Kaiser, I think there it comes from the health plan, but the health plan is the provider group, right? So I've not done the health plan alone. I mean, I know health plans do stuff. Yeah.
All right, well, I think we're out of time. I think what I've concluded from this is that you've got way too much free time and you're not doing enough.
Okay.
But let's thank Jennifer for
Mary Ann.